Hi, I'm Dr. Randy Martin with the Marcus Heart Valve Center at Piedmont, Atlanta, and I'm glad that you've joined us. I'm really glad that Mike Reardon is joining us. Mike, as many of you may know, is the professor of cardiovascular surgery, and he's also the Allison Family Distinguished Chair of Cardiovascular Research at Houston Methodist Hospital. A lot of titles there, but you deserve it. So
well, thank you, sir.
You've done a great job. So, Mike, we could talk about many topics, but I thought it'd be fun to talk about, you know, and you've been really key in a lot of the TAVR stuff. So what's the future of the cardiac surgeon for aortic valve disease?
Well, I think the cardiac surgeon is going to be an integral part of the TAVR team for number one. Okay. I mean, if I look at what happened at my institution when we started our TAVR program, we added over 100 aortic valves to the program and that have been there every year since. So our open procedures went up, as well as the fact that we'll do over 200 TAVRs this year.
Okay.
Going forward, what we're going to find is that I think we're going to have specialized centers for aortic valve surgery where the complex aortic root surgery is done, where aortic repair surgery is done, where dissection surgery is done. So I think the surgeon's going to have a very active role. Cardiologists will be our partners in this.
So, Mike, do you see a young cardiac surgeon, what are they getting trained in if they want to do aortic valve disease?
So our young trainees now spend time in the cath lab.
Okay.
They spend time with our vascular team doing EVAR and TVAR.
Okay.
We start very early teaching both wire skills and imaging skills. Imaging is key to all this. If you don't understand the imaging, you're not going to be a player in the field. And so we start with our new trainees, and then my mid-level faculty, they want to get into this, I tell them you got to go back, you got to learn the imaging, and then once you know the imaging, I'll teach you the wire skills, and then you can be part of the team.
But the specialized guys, so the guys that are going to take on the guerrilla warfare, which is the thoracic aorta and all that stuff, are they going to be separate from the aortic valve surgeons and interventionalists?
Well, I think it places like your valve center and my valve center, the answer is going to be absolutely yes.
Yeah.
I mean, people are now expecting and demanding really superb outcomes with everything that happens. No longer, I mean, you remember when you started, somebody had heart surgery and died, everybody said, well, there was heart surgery.
Right.
That's no longer acceptable.
Right, absolutely.
And perfect results are really demanded. And to do that, you really have to focus on one thing and do it very well. And I don't think my thoracic aortic guy is going to be a mitral valve guy.
No, you're absolutely right. So, Mike, you've been integral in the TAVR studies. Where are we today with TAVR, and where are we going in the future with TAVR?
Well, I think the partner trial and the core valve trials have given us the best data on aortic valve disease that we have anywhere on the planet, no question. And we knew this before, that it's better to have a TAVR than be treated medically. Medical treatment was no treatment. Okay. But also we know that if you're high risk for surgery, you're better off with a TAVR. You do at least as well, 5-year data from partner A, or you do better, 2-year data from core valve, than you do with surgery. Now, it didn't surprise me that TAVR would compete with surgery in the higher risk. If I do a perfect operation in somebody that has many comorbidities, they still die.
Right.
What really surprised me is when I took the core valve 2-year data and I looked at the lower half of the risk, TAVR still won. And so the partner 2A and the Certavi, that's going to be really interesting. If those turn out to be non-inferior or superior, well, then I think that pretty soon anybody that's a candidate for a tissue valve will get a TAVR unless we get a signal for valvular degeneration, which we haven't seen yet.
So you think it's going to move down into the low risk group?
It's absolutely.
I don't think there's any doubt.
Yeah.
And Mike, there have been tremendous developments in TAVRs, haven't they? I mean, on the actual valve, I mean, with decreasing paravalvular leak, decreasing strokes, is that, I mean, the core valve data even looked better than surgery.
Looks better than surgery, yeah, it kind of turned it on its head. Well, the interesting, Randy, is that surgery, we've had surgical aortic valves around for over 60 years. I've personally been doing them for 32 years. This is 1 decade, and look at where we've come. And so you remember the early days. The early days is you'd pace the heart, you'd blow up the valve, everybody held their breath, and either you had a stunning success or a catastrophic failure. Now, things have gotten so simple. Even with the balloon expandable, there's no drama anymore. But you look at things like the Lotus valve, which I do now, you just crank it out slowly. It's never obstructive. You get it 100% to lock. You decide if you like it. If you like it, you let it go. If you don't like it, you move it. The Evolut R is now a recapturable valve. Direct flow is a recapturable valve. I think what we're going to see and what we're going to have to do as we move to lower risk is that the TAVR implanter is going to have to be able to do what I do as a surgeon. That is get the right valve in the right place every single time. And the new valves are letting us do that.
Is there, and I think you're right, I mean, there are going to be dramatic advances. Is there going to be a role for cerebral protection even though stroke risks are going down, a lot of studies still show that there are some stuff going on in the brain post.
Yeah, the answer is we all want our brains protected as much as we can. I mean, I had a minor surgery this year. My wife didn't want me to go to sleep because she was worried it would scramble my brain. I told her my brain started scrambled. That's a separate issue. The issue with cerebral protection is that the concept of blocking particulate matter makes sense. We just have to prove that doing it doesn't do any harm.
Okay. So if you lucked out 10 years, okay, if somebody comes in with aortic stenosis and not aortic root, and they could or could not have concomitant coronary artery disease, how are we going to be treating them, and what do you think that if it's a device, what it's going to look like?
Well, I think if they are a candidate for a tissue valve, and assuming we don't see durability signals that are poor in the TAVR valves, you will get a TAVR valve plus or minus percutaneous approach to your heart, unless you have something there where we know your syntax card is over 33, and we know we can improve your quality, your length of life with a bypass. Now that data may change with time too, as we get more and we look through the FAME series and the FAME 3, which is going on right now. That may change, but currently I would say that you're probably going to end up with a TAVR and a PCI. There's going to be caveats that are going to still pull people back to surgery, and I'm assuming that we're going to solve the PVL risk. I think right now we're talking about moderate to severe. I think in 2 years we won't be talking about this anymore. We'll be talking about mild. And
I'm sorry, I didn't mean to cut you off. You triggered a thought in my mind, which was about certainly there have been advances in the surgical approach with minimal incisions and all that stuff. And I think those are great, but I truly feel that TAVR is going to be the way to go. Am I correct in that?
Yeah, you are, Randy. So we do 90% of our TAVRs at the Methodist Hospital transfemorally. We do most of those under sedation and local anesthesia. Right. They go to the recovery room, they're walking around the room eating dinner with their spouse. I don't care how small incision I make. If I have to put you on the heart-lung machine, you're not going to, in fact, I could probably just put you on the heart-lung machine and stop, and you're still not going to be doing as well, even if I don't open your chest.
No, I think you're exactly right. So ask you two more quick questions. First question is, there's been a lot of recent sort of flurry of thoughts of data based upon a small study that found some thickening of the both surgical and TAVR valves, where they're sort of microthrombus or something like that. Is that a big deal, or what are your thoughts on that?
Well, it is by definition a big deal because it's been thrown to the FDA, which is a political organization, and they need some coverage on this. What we don't know is what this means. Right. So what Raj Makar showed in his paper is that we can detect with TEE and 4D-CT movement abnormalities of valves that cannot be seen on transthoracic TE, and it cannot be measured as a gradient. Now we see this in both surgical valves and in TAVR valves. So it's probably always been there, we've just never looked for it. So to me it's much like when I was young, if you want to know you had a spot in your lung, you got a chest x-ray. Right. If I can see it on chest x-ray, it's probably important because it's got to be about a centimeter. Now I can send you or me for a high definition chest CT and they will find a 1 millimeter nodule. What does that mean? We have no earthly idea. So it's by definition important, but I don't think people should panic until we find out what's going on. To me, this is just another road of research.
In the event of, it really hasn't meant anything clinically, at least in the initial look, isn't that right?
No, and I think it's going to be just like surgical valves. Okay. There's a very low rate of real valve thrombosis in surgical valves, and there's probably going to be a rate of this leaflet movement abnormality. We don't know if it's thrombus. This is seen more in the pericardial valves than the one porcine valve, which is a thinner material, so it may be partially materially based, and just how this opens and closes with sensitive imaging. I don't know what the answer is. I think everybody's concerned. We're going to find out. The FDA wants to know, and we're going to help them find out.
But right now, we're not panicking.
I would not panic, and I would tell my patients, listen, this has probably always been around. We're just getting so good at looking at things.
So, Mike, for last question, tremendous now excitement about mitral transcatheter therapies, okay? What are your thoughts? Where are we going?
Well, I'm really excited. As you know, at the American Heart, the 2-year data from the randomized mitral valve repair versus replacement in ischemic functional MR was presented. And the 30-year failure of repair at 1 year went to 58% failure at 2 years. We as surgeons do not have a good way of treating this. Right. We also saw the ones that got repaired and worked did pretty well. And so if we could eliminate the upfront hit of surgery, I think we may have a winner for these patients. Now, I'm very excited about it. I know you're probably excited about it too. Right now, the early trials, most of them have not looked that good. Some of them have had a 50% mortality. Everybody goes, oh, woe is me, 50% mortality. What they forget is that when Cerebral started the balloon expandable valve, the early mortality was 50%, not 30 days, 30 minutes. Either you had a stunning success or a terrible failure. Now it looks routine. I think 10 years from now we'll be saying the same thing about mitral valves.
But it's going to be, am I correct to think that it's going to be for secondary MR? I mean, if you can do a good repair on primary MR.
I think it'll be secondary MR and primary MR that the surgeon doesn't want to touch for a variety of reasons. We have really good operations for organic mitral regurgitation. And as long as you go to centers where it's really done, not one of the surgeons that's doing 3 a year, you're going to do well.
Well, I mean, it's really exciting times. Listen, you've helped our understanding and our knowledge a lot. I really appreciate it and look forward to your continuing to educate us in the future.
Well, thank you, Randy, and I always learn every time I come here and talk to you.
Thank you. Thanks. And thank you for joining us. We'll hope that you'll watch us more often. Thanks.